Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Maternal Delivery and Manage Pregnancies and Deliveries with Appropriate Interventions. 4.1 Introduction. Medical complications during pregnancy often adversely affect course and outcome of pregnancy. Pregnancy often has the effect of aggravating the associated medical disorders. Maternal and perinatal morbidity and mortality are also found to be increased in pregnancy. Complicated by these disorders, outcome of these pregnancies can be significantly improved if these complications are timely diagnosed and effectively managed during pregnancy. Labor and puerperium. Pre-pregnancy counseling prepares these women for conception at right time and many complication can be avoided and minimized. One should also remember the alterations in the diagnostic and treatment plans which are to be made during pregnancy, which otherwise are used in the non-pregnant state. Results can further be improved if cases which are too complicated to be managed in the existing healthcare setups are timely referred to more specialized units which are better equipped and have considerable experience in the management of such cases. In this unit, emphasis has been placed on diagnosis and management of these disorders during pregnancy and effect of interaction between the disease and pregnancy. 4.2 Heart disease in pregnancy. Organic heart disease is a serious complication in pregnant women. After hypertension, hemorrhage and infection, it is fourth most common cause of maternal death and most common indirect cause of maternal mortality incidence as 1% amongst hospital deliveries. Types of heart lesion. 1. Rheumatic valvular heart disease leading to mitral stenosis, mitral regurgitation. 2. Congenital atrial or ventricular septal defect, patent ductus arteriosus, coarctation of aorta, pulmonary stenosis. 3. Other rare causes, hypertensive, thyrotoxic, syphilitic, coronary and cardiomyopathies. Commonest cardiac lesion being that of rheumatic origin, which predominantly includes mitral stenosis, 80%, followed by the congenital one. Over the years there is decrease in frequency of rheumatic fever and rheumatic heart disease, and because of improvement in the medical and surgical therapy for congenital heart disease, more cases of congenital heart disease are seen complicating pregnancy. 4.2.1 Diagnosis and evaluation during pregnancy. Heart disease may be detected for the first time during pregnancy or more commonly a woman with heart disease presents for medical care after she has become pregnant. Clinical findings due to physiological changes of normal pregnancy closely simulate those of organic heart lesions, leading to diagnosis of heart disease more difficult than in non-pregnant state. Presence of any one of the following criteria confirms organic heart disease during pregnancy. 1. Presence of diastolic murmur. 2. Cardiac enlargement. 3. Loud harsh systolic murmur associated with thrill. 4. Presence of arrhythmia. You must remember to do a careful clinical examination of the cardiovascular system in all antenatal patients, and whenever heart disease is clinically suspected or diagnosed, patient should be referred to cardiologist for confirmation and cardiac treatment. Ultimate clinical diagnosis made by you should be a composite one including etiology, structures involved, and functional grading. The degree of functional disability is graded according to New York Heart Association NYHA classification, which is as follows. Class 1, patients with cardiac disease but no limitation of physical activity. Class 2, patients with cardiac disease with slight limitation of physical activity. These patients are comfortable at rest but ordinary physical activity causes discomfort. Class 3, patients with cardiac disease with marked limitations of activity. Discomfort occurs with less than ordinary activity. Class 4, patients with cardiac disease with discomfort even at rest. Grading of cardiac lesion should be done whenever a patient is seen on first obstetric visit. Grading may change during pregnancy. Grading is a rough guideline and reflects the severity of the disease. 4.2.2 Effect of heart disease on pregnancy. There is an increased risk of intrauterine growth retardation, preterm delivery and fetal death. Reason: inability to maintain adequate uteroplacental circulation due to chronic hypoxia. If mother has congenital heart disease, there is increased incidence of congenital heart disease in the fetus, 4.5% vs 0.6% in overall population. 4.2.3 Effect of pregnancy on maternal heart disease. Due to hemodynamic changes of pregnancy, there is increased risk of congestive cardiac failure, pulmonary edema, subacute bacterial endocarditis. Most dangerous period for cardiac failure during pregnancy. One must remember that there are several periods during pregnancy when the danger of Cardiac decompensation is especially increased. The first is between 12 and 32 weeks of gestation, most critical being between 28 and 32 weeks, when the hemodynamic changes of pregnancy peak and cardiac demands are maximum. The second dangerous time is during labor and delivery. As during labor, every uterine contraction injects blood from the uteroplacental circulation into the maternal bloodstream, increasing cardiac output which may trigger congestive cardiac failure. Immediately after delivery also, there is sudden transfusion of blood from lower extremities and the uteroplacental vascularity to the systemic circulation, increasing the risk of congestive cardiac failure. 4.2.4 Management, care during pregnancy, labor and puerperium. Antenatal visits should be in consultation with a cardiologist at interval of 2 weeks up to 24 weeks and thereafter at weekly intervals. At each visit one must look for signs of congestive cardiac failure, breathlessness and cough, crepitations at lung bases, tachycardia. If pulse rate is persistently high, more than 100 beats per minute, she requires hospitalization. You also have to measure blood pressure and weight, re-evaluate functional grading of the heart, do routine antenatal checks in addition. Advice: rest. Maximum rest is advised. Patients should rest in bed 10 to 12 hours each night and 2 hours in the afternoon. Diet should contain low salt to prevent excessive fluid retention. Avoid excess weight gain, because it places additional burden on the heart. Avoid anemia by adequate iron and folate supplementation. Avoid infection, as it may precipitate heart failure. Intramuscular injection of Penedio La12. Benzathine penicillin may be given at intervals of 3 weeks throughout pregnancy and puerperium to prevent recurrence of rheumatic fever. Emphasize the need to follow the advice of the cardiologist. Hospitalization. Grade 1 should be admitted at 38 weeks of gestation to ensure that labor begins under optimal conditions and in the absence of congestive cardiac failure. Grade 2, admit at 28 weeks and keep hospitalized till delivery. Grade 3 and IV should remain in the hospital throughout pregnancy. Management of cardiac failure. Immediate treatment should be started preferably in consultation with a cardiologist and is as follows. 1. Patient is placed in propped up position. 2. Oxygen inhalation. 3. INJ morphine 15 mg intramuscular. 4. Digitalization. Digoxin 0.5 mg is given intramuscular followed by tab digoxin 0.25 mg orally at interval of 6 hours till emergency passes off. Digoxin crosses placenta but no adverse fetal effects have been noted with therapeutic maternal levels. 5. Diuretics. INJ furosemide, Lasix, 20 mg should be given intravenous or intramuscular, followed by tab Lasix 40 mg daily. 6. Aminophylline, 250 mg is given intravenously in acute phase, to relieve bronchospasm, and is followed by oral therapy. Fetal monitoring should be done carefully as these patients have high incidence of antepartum asphyxia and intrauterine growth retardation. Repeated ultrasonography may be helpful for assessing fetal growth and well-being. Ultrasonography is also important for the diagnosis of congenital malformations. Cardiac surgery during pregnancy, it is better avoided during pregnancy. If it has to be done, the best time is between 16 to 20 weeks of pregnancy. Indications for mitral valvotomy or balloon angioplasty during pregnancy are: 1. Development of pulmonary edema not responding to medical management. 2. Profuse and uncontrollable hemoptysis. 3. Progressive pulmonary hypertension. Placement of prosthetic heart valve during pregnancy, although it is advisable to postpone open heart surgery until after pregnancy. Occasionally valve replacement during pregnancy may be life-saving. Patients with valve replacement are at increased risk of thromboembolism. Anticoagulant therapy which they have to take lifelong is to be continued throughout pregnancy and puerperium. Role of termination of pregnancy. Termination is rarely required solely on grounds of cardiac disease. Cardiac lesions, which carry high risk and in which termination is indicated, are primary pulmonary hypertension, Eisenmenger syndrome and severe ischemic heart disease. Care during labor and delivery. As we know that the patient is prone to heart failure during labor, following measures should be adopted. She should be kept in propped up, semi-recumbent position. Oxygen should be administered if she suffers dyspnea. Intramuscular injection of pethidine hydrochloride 100 mg should be given for effective relief from pain and apprehension. Daily dose of drugs, digoxin, Lasix, to be continued during the labor. Monitoring of pulse and respiration, if pulse rate exceeds 110 per minute or if respiratory Rate is above 24 per minute, it suggests cardiac decompensation, for which intensive medical management should be instituted immediately. Prophylactic antibiotics should be given during labor to avoid the possibility of subacute bacterial endocarditis. For this purpose, combination of ampicillin 2-GM1M or IV and gentamicin 1.5 mg per kilogram body weight, IM or IV followed by second dose of both 8 hours later, should be administered. Repeated per vaginum examinations should be avoided and should be done only if absolutely necessary, to reduce the chances of infection. Second stage of labor, this stage is usually quick in cardiac cases. If there is any delay, it should be shortened by application of outlet forceps or vacuum extraction. Ventouse is preferable to forceps as it can be applied without putting the patient in lithotomy position. Raising the legs increases the cardiac load. Third stage of labor, routine use of prophylactic intravenous ergometrine should be avoided, to prevent sudden overloading of the heart by additional blood squeezed out from the uterus. However, if blood loss is excessive, INJ ergometrine 0.5 mg 1 or oxytocin infusion should be administered. Place of caesarean section in a heart disease patient. Heart disease as such is not an indication for caesarean section, which should be done only for obstetrical indications. The anesthesia should be given by an expert anesthetist using epidural or general anesthesia. Trial of labor should not be done in heart disease patients. Induction of labor is not indicated for heart disease alone and should never be done if the patient is in acute cardiac failure. If induction is to be done for obstetrical reasons, best method is by syntesinone infusion in relatively concentrated solution. Care during puerperium. Delivery and immediate puerperium are the periods of maximum risk for cardiac failure. Hence, intensive monitoring should be continued for several days following delivery. One should closely monitor the patient for signs of heart failure, hypotension and arrhythmia. Can be discharged 10 to 14 days after delivery, after full assessment by a cardiologist. Breastfeeding is not contraindicated unless patient is in cardiac failure. Contraception, permanent sterilization should be considered after completion of family and is best done at the end of first week in the puerperium, provided the heart is well compensated. Barrier contraception, condom, is best for spacing. Steroidal contraception is contraindicated as it may precipitate thromboembolic phenomenon. Intrauterine devices are best avoided because of fear of infection. Congenital heart disease. Patients with congenital heart disease are surviving to the childbearing age because of availability of better diagnostic techniques, medical and surgical management. It can be cyanotic or acyanotic. Prognosis for the patients with cyanotic heart disease is significantly worse for the mother and fetus, hence they should be advised against pregnancy unless the lesion is corrected surgically. Ideally, most women entering childbearing age should have surgical repair of significant defects. Congenital heart lesions which carry significantly high maternal risk include Eisenmenger syndrome, Epstein anomaly, coarctation of aorta with hypertension and tetralogy of Fallot. 4.3 Diabetes mellitus. 4.3.1 Definition. Diabetes mellitus, it can be defined as a state of carbohydrate intolerance resulting from inadequacy of insulin secretion or ineffectiveness of insulin action. Pregnancy causes a diabetogenic influence on the normal and on existing carbohydrate abnormality. Gestational diabetes, it is carbohydrate intolerance of variable severity with onset or first recognition during present pregnancy. It requires reclassification after delivery. Glucose tolerance test should return to normal 6 weeks after delivery. Risk of fetal morbidity and mortality is increased and can be prevented by appropriate treatment. 4.3.2 Diagnosis of diabetes mellitus. Diabetes is self-evident in patients with abnormal carbohydrate metabolism before pregnancy requiring diet or insulin therapy to maintain metabolic control. Diagnosis of gestational diabetes. You must remember that vast majority of pregnant women with diabetes have gestational diabetes of which there are no signs or symptoms, and can be diagnosed only through the laboratory tests. Screening for diabetes should be done during pregnancy and a glucose tolerance test, GTT, should be done in patients at risk for diabetes during pregnancy. Following are the indications for GTT during pregnancy. 1. Positive family history of diabetes in the first-degree relatives, sibling or parent. 2. Gross obesity. 3. Previous history of unexplained perinatal death, delivery of a large infant, greater than 4,000 grams, congenital anomaly, prematurity. 4. Significant glycosuria, second fasting specimen of urine showing glycosuria. 5. Development of macrosomia, polyhydramnios. 6. Recurrent severe moniliasis, urinary tract infections. 7. If fasting blood sugar exceeds 90 mg per deciliter or if 2 hours postprandial blood sugar exceeds 120 mg per deciliter on routine checkup. How should you do GTT, glucose tolerance test, in pregnancy? Patient is instructed to consume high carbohydrate diet for at least 3 days before the test. On the day of the test, a fasting blood sugar sample is taken. Then she is given 100 grams of glucose load. Blood sugar samples are drawn 1, 2 and 3 hours later. Concomitant urine sugar is also done to detect glycosuria and to determine appropriate renal threshold. For glucose, how should you interpret glucose tolerance test result in pregnancy? Following are the upper limit of normal, whole blood glucose values for the 3-hour GTT. Fasting 90 mg per deciliter. 1 hour 165 mg per deciliter. 2 hours 145 mg per deciliter. 3 hours 125 mg per deciliter. If 2 or more of these values are abnormal, the patient has gestational diabetes. When should GTT be performed during pregnancy? You should screen for GTT between 24 to 28 weeks of gestation. 4.3.3 Effect of pregnancy on diabetes. More insulin is necessary to achieve metabolic control, and there is tendency toward metabolic instability during pregnancy. There may be progression of diabetic retinopathy and worsening of diabetic nephropathy. 4.3.4 Effect of diabetes on pregnancy. You should know that a diabetic pregnancy is more prone to certain complications, which are 1. Spontaneous abortions. Risk of abortion is more in uncontrolled diabetics. 2. Polyhydramnios is common due to large fetus, large placenta, fetal polyuria due to maternal and fetal hyperglycemia. 3. Preeclampsia. Risk is increased about 4 times and contributes to increased perinatal mortality. 4. Infections. There is higher incidence of asymptomatic bacteriuria, urinary tract infections and monilial vulvovaginitis. Effect of maternal diabetes on the fetus and newborn. 1. Perinatal morbidity and mortality is considerably increased compared with that of general population, and it basically depends upon degree of blood sugar control. 2. Congenital malformations. There is threefold increased risk of major malformations in women with overt diabetes, its incidence being around 4%. Most common anomalies are that of heart and central nervous system and include anencephaly, spina bifida, transposition of great vessels and ventricular septal defect. Strict control of diabetes in the periconception period reduces incidence of malformations. 3. Macrosomia and birth trauma. Diabetic infants are oversized and edematous due to excessive deposition of fat. Mechanism of macrosomia. Maternal hyperglycemia results in excess transfer of glucose to the fetus. Registered hyperplasia of fetal pancreatic beta cells. Registered increased secretion of fetal insulin resulting in carbohydrate utilization and increased deposition of fat. Strict control of diabetes can prevent fetal macrosomia, which occurs in 30 to 40% cases of gestational and overt diabetes. Fetal macrosomia results in increased incidence of birth injuries including shoulder dystocia, fracture of clavicle. 4. Intrauterine death of fetus is most likely to occur in the last 4 weeks of pregnancy. Incidence high is uncontrolled diabetics. Adequate control of diabetes can prevent fetal death. 5. Respiratory distress syndrome. Pulmonary maturity is delayed due to hyperinsulinemia resulting in delayed pulmonary surfactant formation and respiratory distress syndrome. 6. Neonatal hypoglycemia mechanism. Fetal hyperinsulinemia continues after delivery, which results in glycogen storage leading to hypoglycemia. 7. Hyperbilirubinemia, hypocalcemia and hyperviscosity. 4.3.5 Management during pregnancy, labor and puerperium. Our aim of management should be L. Achieve metabolic state similar to that of non-diabetic pregnancy. 2. Avoid iatrogenic prematurity. 3. Detect intrauterine fetal distress before fetal demise. 4. Avoid maternal complications. Management starts before conception. Pre-pregnancy counseling, in which you should stress the importance of strict control of diabetes at the time of conception and throughout pregnancy. Once a woman desires pregnancy, she should be changed over to insulin for better control of diabetes in the periconceptional period. Estimation of glycosylated hemoglobin, HbA1c, is a method of looking retrospectively at diabetic control. The concentration of HbA1c reflects mean plasma glucose concentration during previous 6 to 8 weeks. Value above 8% is associated with Increased risk of perinatal mortality and congenital malformations. One should properly assess whether the patient is fit to become pregnant, and one may have to treat retinopathy or hypertension before allowing pregnancy. Chances of offspring having diabetes should be explained and are 1% if only mother is diabetic. If mother and father both are diabetic, chances of diabetes in the offspring become 5%. The risk of offspring suffering from diabetes is 3 times than in general population. Management during pregnancy. Antenatal care. You should teach the patient self-glucose monitoring and advise hospitalization if there is any problem of blood sugar control. How to check for blood sugar control? Blood sugar can be checked with dextrose, glucometer, or by frequent blood sugar estimations. Urine testing is inadequate for blood sugar control due to lowered renal threshold during pregnancy. A complete blood sugar profile includes blood sugar testing immediately before each meal, 2 hours after each meal, just before bedtime, and at 2 a.m. On such 24-hour blood sugar profile, modification in dietary intake or insulin dosages are carried out. Goal of metabolic control in pregnancy is to keep mean daily blood sugar levels below 100 mg per deciliter without ketonuria or hypoglycemia. For this purpose, fasting blood sugar should be below 100 mg per deciliter and postprandial below 140 mg per deciliter. One must remember that diet and insulin both are important for blood sugar control. Diet alone may control gestational diabetes. Diet should exclude simple sugars. Total daily calorie requirement is 30 to 35 kilocalories per kilogram of ideal body weight. As pregnancy is ketogenic, allowance for carbohydrate should be generous and should be 50% of total calorie allowance. Rest 25 to 30% calories should be from protein and remaining 25 to 30% from fat. What is the role of oral anti-diabetic drugs for management of diabetes during pregnancy? They should not be used during pregnancy as they cross the placenta and may have teratogenic effect or produce neonatal hypoglycemia. Insulin therapy. Indications of insulin therapy in pregnancy are: patient who was having oral anti-diabetic or insulin therapy in the pre-pregnant state. Gestational diabetics who can't be controlled on diet alone. Insulin requirement increases with advancing gestation. Most patients require twice daily injections of a mixture combining a quick-acting insulin and one of intermediate duration. Most commonly employed regimen is combination of intermediate-acting and regular insulin before dinner and breakfast. Patients usually receive 2/3 of total insulin dose with breakfast and remaining 1/3 at supper time. Morning insulin is a mixture of intermediate-acting and regular insulin in a ratio of 2:1 and remaining 1/3 of insulin dose is given before dinner in 1:1 ratio, i.e. equal amount of intermediate-acting, NPH, regular insulin. Dosage and composition of mixture may have to be modified depending upon periodic plasma glucose readings. Other investigations. Apart from routine investigations, urine culture should be done at initial visit and repeated at 4 to 6 weeks interval. Fundus examination to detect diabetic retinopathy. Renal function test. Ultrasonography should be done in all cases to rule out congenital malformations at 16 to 18 weeks of pregnancy and may be repeated to assess fetal growth, to rule out fetal macrosomia and for biophysical assessment. Assessment of fetal well-being is very important as these cases have increased risk of intrauterine death. Clinical examination should be done at each antenatal visit including assessment of amount of liquor, amni and size of the fetus. Cardiotachography and ultrasound-guided biophysical profile are also done to ensure fetal well-being. Frequency of these tests depends upon severity of the disease and presence of other complications. Time and mode of delivery. You should allow term delivery in cases of gestational diabetes with good blood sugar control and well-controlled patients with overt diabetes. Advantages of term delivery include frequent onset of spontaneous labor, assured lung maturity, less neonatal morbidity. Induction of labor is done at 38 weeks or earlier if patient is an unstable diabetic. There is evidence of fetal distress or intrauterine growth retardation. Presence of maternal complications like preeclampsia. Induction of labor if done prior to 38 weeks of pregnancy. Lung maturity should be ensured to reduce the risk of respiratory distress syndrome in the neonate. Tests to assess lung maturity are estimation of lecithin, sphingomyelin ratio in the liquor, amni, a ratio of 2 or more. Guparanti's lung maturity, presence of phosphatidylglycerol in the liquor, which is a more specific test than L/S ratio. Mode of delivery. Vaginal delivery is aimed for and caesarean section should be done only for obstetrical Indications. One added advantage of vaginal delivery over caesarean section is reduced risk of respiratory distress syndrome. Management during labor. Duration of labor should be limited and delivery should be conducted without trauma. Control of diabetes during labor. Our aim is to maintain the blood sugar as near to 100 mg per deciliter as possible during labor. To achieve this, 1 to 2 hourly estimations of blood sugar are done throughout labor and the insulin dose is adjusted accordingly. Urine sample should be sent for acetone. If labor is to be induced, no breakfast, no insulin on the morning of induction. Start 500 ml of 5% glucose IV drip and add 5 units of plain insulin in the drip. Drip should be given at a rate of 125 ml per hour. If the patient is to undergo elective caesarean section, no breakfast, no insulin in the morning. 1V saline drip should be started in the morning. Blood sample is sent for sugar estimation. Procedure should be scheduled early morning to simplify glucose control. Remember that insulin requirements in these patients during labor and delivery are low. Management in the puerperium. Following delivery, insulin requirement dramatically falls and majority of patients do not require insulin for 24 to 48 hours. Blood surga estimations should be repeated and patient should be started with half of her pre-pregnancy dose of insulin and further managed according to blood sugar levels. Breastfeeding is encouraged. Insulin requirements may be lower in lactating women. Prophylactic antibiotics should be given to prevent infections. Contraception. Sterilization should be advised once family is complete. Barrier methods. Condom should be used for spacing of birth. Oral contraceptives are best avoided as they are likely to intensify diabetes. Intrauterine contraceptive device increases the incidence of pelvic infections. 4.4 Urinary tract infection. This includes asymptomatic bacteriuria and pyelonephritis in pregnancy. 4.4.1 Asymptomatic bacteriuria. It is defined as presence of significant amount of bacteria, greater than 100,000 per milliliter, in the midstream specimen of urine on 2 occasions, in a patient without any symptoms. Incidence ranges from 2 to 10% during pregnancy. E. coli is the offending organism in over 80% of cases. Significance. If asymptomatic bacteriuria is untreated in pregnancy, 25 to 30% women will develop acute pyelonephritis. There is higher risk of pregnancies being complicated by anemia, hypertension, preterm labor and low birth weight babies. Women also run a greater risk of developing chronic renal lesion in later life. Treatment. About 60 to 70% of all pyelonephritis cases can be prevented by finding and treating asymptomatic bacteriuria during pregnancy. Treatment consists of 7 to 14 days course of antimicrobial therapy according to culture and sensitivity report of urine. Cephalosporins and ampicillin are amongst safe antibiotics to be used during pregnancy. 4.4.2 Pyelonephritis. It is the infection of renal pelvis, ureter as well as renal parenchyma. Incidence between 1 to 2%. Diagnosis by presence of fever with chills and rigor, flank pain, dysuria together with a positive urine culture. Effect on pregnancy. There is higher incidence of abortion, preterm labor, intrauterine growth retardation and intrauterine fetal death due to hyperpyrexia. 4.4.3 Management of UTI. Management of UTI could be preventive or curative. Prevention is done by detecting and treating asymptomatic bacteriuria adequately. Curative measures. In acute attack, patient should be hospitalized. Midstream urine should be collected for protein, sugar and pus cells. Urine is cultured for organisms and sensitivity tested for antimicrobials. If there is fever with vomitings, LNTRA venous fluids may be necessary. Urinary output is carefully measured. Specific therapy includes administration of antimicrobial drugs by oral route or by intravenous route in more acute cases. Ampicillin or a cephalosporin is usually administered intravenously in a dose of 1 to 2 grams every 6 hours. If there is no appropriate response, injection gentamicin 60 to 80 mg 1 m is added 8 hourly. After obtaining culture and sensitivity report, appropriate antimicrobial agent can be selected. Once acute phase is over, oral therapy with cephalosporin or ampicillin 500 mg 4 times a day is continued for 10 to 14 days. Alternatively, 10 to 14 days course of nitrofurantoin, fludarabine, 100 mg thrice a day, should be given depending on culture and sensitivity. Report. Periodic culture of urine will assist in detecting recurrence. In case of relapse or reinfection, antibiotic course should be repeated and in such cases low dose Antimicrobial prophylactic therapy, nitrofurantoin 100 mg every night, is recommended throughout pregnancy. 4.5 Malaria. Malaria is predominantly a tropical disease. Malaria is transmitted by saliva of anopheles, mosquitoes, or by blood transfusion. The diagnosis is made on clinical features confirmed by the detection of malaria parasites in peripheral thick blood smear. 4.5.1 Effect on pregnancy. There is increased incidence of abortion, preterm labor, intrauterine growth retardation, and stillbirth. These are caused by pyrexia itself and/or placental infection. Transplacental infection, which is rare, leads to congenital malaria and neonatal death. 10% fetus are born to women with plasmodium infection and will have the parasite in the cord blood. Primigravid are more susceptible to infection than multigravid. Exacerbation or relapse is also common in them. Severe complications of malaria include cerebral malaria resulting in coma, convulsions, severe hemolysis, and acute renal failure. In the fetus, there is decrease in 200 to 300 grams of birth weight due to malaria. Differential diagnosis: urinary tract infections, viral infections, other causes of pyrexia. Appropriate investigations will help in arriving at the correct diagnosis. 4.5.2 Treatment in pregnancy. Chloroquine is the drug of choice during pregnancy. Tab chloroquine phosphate, Lariago, 4 tablets, 600 mg initially, followed by 2 tablets after 6 hours, thereafter 1 tablet twice daily for 2 days. Total 10 tablets are required. Chloroquine in above dose does not affect fetus. Alternatively, you can give amodiaquine, camoquine, 3 tablets, 600 mg initially, followed by 2 tablets daily for 2 days. In pernicious malaria, chloroquine should be given parenterally. As a prophylaxis, chloroquine 2 tablets a week is quite effective until 6 weeks postpartum. 4.6 Pulmonary tuberculosis. Incidence: pulmonary tuberculosis complicates 1 to 2% of pregnancies in our country. The tubercular lesions in the lung may be active or quiescent. 4.6.1 Diagnosis. Most cases can be diagnosed on the basis of a history of cough and weight loss, positive tuberculin skin test, and X-ray chest. X-ray is not done routinely in pregnancy and should specially be avoided in the first trimester because of risk to the fetus. In patients with suggestive history or physical examination, chest X-ray should be done after shielding the abdomen to confirm the diagnosis. 4.6.2 Treatment in pregnancy. Treatment of active tuberculosis during pregnancy is only slightly different from that in non-pregnant patients. Drug treatment should be done in consultation with a physician. Patient should be given isoniazid, Isonex, 300 mg orally along with tablet ethambutol 800 mg daily. In active cases, treatment is continued for 18 months to prevent relapse. Addition of one or more drugs may be necessary to reduce the prolonged duration of treatment or in cases with extensive or severe disease. Because of the risk of ototoxicity to the newborn, streptomycin should be best avoided during pregnancy. The role of rifampicin in congenital malformations is not clear and should be given only after the first trimester is over. Isoniazid appears to be the safest drug during pregnancy. Pyridoxine 50 mg per day should be administered to prevent isoniazid-induced neuritis due to vitamin B6 deficiency. Breastfeeding. It is not contraindicated once the mother is non-infectious. However, if the lesion is active, and in sputum-positive cases, baby should be separated from the mother following delivery. The baby should be vaccinated with BCG as soon as possible and kept segregated for 6 to 9 weeks till Mantoux test becomes positive. Prognosis. If the pregnant patient is adequately treated with anti-tubercular chemotherapy for active disease, tuberculosis generally has no deleterious effect on the course of pregnancy or on the fetus. Pregnancy, if properly managed, also has no harmful effect on the course of pulmonary tuberculosis. Therapeutic abortion is also not recommended for most tuberculosis patients. 4.7 Jaundice. As you already know, jaundice is diagnosed when there is yellow discoloration of mucous membranes, sclera, and skin. Jaundice during pregnancy could be caused by cholestasis due to steroid hormones or other causes. In our country, viral hepatitis is the commonest cause of jaundice. Viral hepatitis can become a serious condition during pregnancy and is a indirect cause of maternal mortality and also perinatal mortality. 4.7.1 Causes of jaundice during pregnancy. The causes of jaundice are listed below. Viral hepatitis, infective hepatitis, cholestatic jaundice, also known as intrahepatic cholestatic jaundice of pregnancy or recurrent jaundice of pregnancy, HELLP syndrome. fatty liver during pregnancy, hyperemesis gravidarum, drug toxicity, infection, malaria, leptospirosis, salmonella, disseminated tuberculosis. 4.7.2 Diagnosis. This section deals with diagnosis of various causes of jaundice and management. I. Viral hepatitis. Hepatitis is caused by different types of virus, e.g. A, B, C, D and E. Hepatitis A is endemic. In our country, infection with A virus is similar in character to A but is a more serious condition and causes endemics in developing countries with significant maternal mortality. Hepatitis A, C and A are transmitted through enteric route. You may be already aware that hepatitis B is transmitted through parenteral route, blood transfusion, unsterile syringes and needles, sexual intercourse and vertical transmission from mother to fetus. Because of chronic carrier state and vertical transmission to fetus, hepatitis B is important to healthcare providers. Hepatitis D is similar in character to B and requires concomitant infection with hepatitis B virus. Since clinical presentations of acute disease overlap, specific diagnosis is possible only by specific serological markers, antigen for HAV, HBV, HCV, HDV and HEV and/or IgM antibodies to these antigens. Hepatitis B infection is usually tested by HBs AG as it is a marker for ongoing HBV infection. Clinical course of HBV infection is shown below. Look at the screen. Because of the need for extensive laboratory investigation, all women having jaundice during pregnancy should be referred to tertiary care centers. All pregnant mothers should be screened for HBs AG during first antenatal visit wherever possible. If found positive, their neonates should be administered hepatitis B immunoglobulin, 0.5 ml 1 m, within 12 hours after birth and active immunization with hepatitis B vaccine, within 12 hours after birth, 1 month and 6 months -0.5 ml vaccine IM. Since transmission during vaginal delivery is not conclusively proved, there is no indication for elective cesarean section. Breastfeeding is not contraindicated and baby need not be separated from the mother at birth as these practices do not prevent infection in the neonate. Cholestatic jaundice of pregnancy. After viral hepatitis, this is the next common cause of jaundice during pregnancy. Generalized pruritus, mild jaundice and intrahepatic cholestasis occurs in the third trimester. Itching becomes severe and all symptoms are relieved in 2 to 3 days following delivery. If you take a proper history, you will elicit history of jaundice in past pregnancies and also in the family. History of jaundice. The cholestatic jaundice of pregnancy has a genetic predisposition and is due to increased sensitivity to sex steroid hormones and altered membrane composition of bile ducts and hepatocytes, HELLP syndrome. You will be reading more about it in Unit 7. Some women with severe preeclampsia may develop hepatic dysfunction and present as hypertension, elevated liver enzymes and low platelet count, HELLP. It may be associated with severe pain in right hypochondrium due to subcapsular hemorrhages and jaundice and may develop DIC. Mothers with severe hypertension, preeclampsia should be referred and treated in a referral center. IV, acute fatty liver of pregnancy. It is a rare condition seen in obese premigravid women. Preeclampsia and multiple pregnancy may be associated. Maternal and fetal mortality are high. V. Hyperemesis gravidarum. Excessive vomiting leads to prolonged starvation and dehydration and these cause hepatic dysfunction. This can be controlled by correcting dehydration, ketosis and control of vomiting. V. Drug toxicity. Drugs such as rifampicin, isoniazid, tetracycline, paracetamol, methyl dopa can cause hepatic dysfunction and you should ask for history of taking these drugs currently or in the immediate past. V. Infection. Infection with malaria, leptospirosis, salmonella and disseminated tuberculosis can cause hemolysis and jaundice. Associated other symptoms and signs may be present. Specific investigations are required in such cases. You would have realized by now that jaundice with pregnancy is a serious condition and requires referral to appropriate referral centers for investigations and treatment. 4.8 Summary. In this unit you have learnt about medical diseases like heart disease, diabetes mellitus, urinary tract infections, malaria, tuberculosis and jaundice complicating pregnancy. Association of heart disease with pregnancy increases the risk of many fetal and maternal complications. Fetal outcome is compromised due to increased incidence of intrauterine growth retardation, preterm delivery and perinatal death. Maternal morbidity and mortality is also increased with increased risk of congestive cardiac failure, pulmonary edema, and Subacute bacterial endocarditis. There is no doubt that pregnancy involves greater risk for cardiac patients, but with constant supervision throughout pregnancy, labor and puerperium, the fetal and maternal morbidity and mortality can be greatly reduced. In this unit, we also discussed abnormalities of carbohydrate metabolism, namely diabetes mellitus and gestational diabetes complicating pregnancy. You learned that the association of diabetes in pregnancy is an additional risk to the mother and fetus. You also learned that the incidence of maternal and fetal complications can be reduced to great extent if the blood sugar is properly controlled. To achieve good perinatal outcome, control of blood sugar should start even before conception, should continue throughout pregnancy, labor and delivery. Diet and insulin both are important for blood sugar control. You also learned how to diagnose and manage common medical problems like urinary tract infections, malaria and tuberculosis during pregnancy, with emphasis on alteration in management plans in consideration to pregnancy. The section on jaundice during pregnancy will help you to manage this not so rare a complication. Thank you for WATC.